Okay, it looks like we have some attendees coming in, so I'm just going to give it a minute and let the room fill up a bit. Okay, in the interest of starting on time, I'd like to welcome everybody tonight for the panel where we'll be talking about the mental health impact of COVID-19. I appreciate all of you showing up this evening and spending some time with Emory. I really want to thank all of our panelists and our moderator, Brad Pomerantz, who I'm going to turn it over to right now. Brad?
Chloe, thank you so much. Yes, my name is Brad Pomerantz, and I am the husband of Tina Fuller Pomerantz, Emory College class of 1994, and the father of Ivy Pomerantz, Emory College class of 2024. Yes, she was just admitted and is planning on attending this fall. Please let her start in August. We'll see if that happens. Professionally, I am a television host, and for the purposes of this conversation, I'm most proud to have recently produced an award-winning special presentation entitled Mental Health in Jewish Americans, which some may say is an oxymoron, but we'll just move on from that. I am honored to be moderating this panel, the mental health impact of COVID-19, especially given, as Dr. Bonds reminded me, that May is Mental Health Awareness Month. Now, you don't want to hear from me, you want to hear from our experts, so it's my honor to introduce them. First, Dr. Curly Bonds. He's a 1987 graduate of Emory College. He is the Chief Medical Officer of the Los Angeles County Department of Mental Health and holds faculty appointments at UCLA and Charles Drew University. Say hi, Dr. Bonds.
Hi there.
Next, we have Dr. Charles Scott, a 1982 graduate at Emory College and 1986 graduate of Emory Medical School. He's a professor of clinical psychiatry at UC Davis, and he is also the chief of the university's Division of Psychiatry and Law, as well as the director of forensic psychiatric training. And of course, we have Dr. Elaine Walker. She is the Charles Howard Candler Professor of Psychology and Neuroscience at Emory University. Her current research focus, adolescents and young adults who are showing a range of psychiatric symptoms that put them at risk for development of serious and sometimes chronic mental illness. It is my honor to be with all of you today and my honor to be speaking with the Emory community. And I want to start our conversation broadly and ask each of our individual panelists about individuals who prior to the pandemic were accessing mental health services versus those that were not. And the reason I asked that is I was talking to my mental health professional, and she had mentioned that while it may seem counterintuitive, she and her colleagues are finding that people who already were in the mental health system are actually doing a bit better during the pandemic than those that were not. So why don't we start with Dr. Walker? You're on the screen right now. What do you think about that point of those in or out of the mental health system?
Mm-hmm. That's a very interesting question. I also often encounter people who have struggled with challenging mental health issues, yet they seem to be handling the stress of COVID with impressive skill. So for someone already in the mental health care system, we would assume they've demonstrated the inclination to seek and pursue treatment. And this probably reflects their ability to acknowledge mental health issues and to actively seek help.
It's as if we've been preparing for this our whole lives. I mean, I jest, but think about it. I mean, in a lot of ways, you know, those that are already in the mental health system have a sense of how to address these types of challenges. There's a resilience and grit. Dr. Scott, what's your sense of those that are already in the mental health system and those that are not during the COVID crisis?
Yeah, we've certainly had this discussion with my colleagues, and one of the I think the new normals that will happen as a result of COVID-19 is there's going to be a significant conversion of regular visits to telepsychiatry or telemedicine. And so when people look at how are people coping, are they coping better if they're already in the mental health system? Well, the answer is yes, but. Yes, but because they already have access to psychiatrists and psychologists and counselors who are able to use Zoom or other features to have ongoing evaluations. I've worked with other individuals who, for the first time, want to initiate care, and if the clinics are closed and the onboarding, if you will, or starting care, that can be more difficult. So at UC Davis, although we had a telepsychiatry presence, we now realize that even when COVID hopefully tapers down and ends one day, we will continue to have a large ongoing telepsychiatry presence. And individuals who have never accessed Zoom or telepsychiatry because of those perceived barriers of electronic difficulty, now that they've got it up, they will tell us, we really like this better. We don't have to wait in the waiting room.
Right.
We don't have to drive. It's really better for certain individuals with serious mental illness that have trouble accessing care, traveling, parking, all of those other barriers. So we may end up to a more vulnerable population having a better long-term outreach.
Let me ask you, I wanted to talk about telemedicine because that is becoming an increasing trend even pre-pandemic. What's your sense about the efficacy or effectiveness of telepsychiatry, telepsychology during COVID-19 or otherwise?
Yeah, I can, Dr. Walker, do you want to go ahead and start?
Oh, certainly. I'll say a few things about that. We have found it to be an outstanding resource. And I think we may be seeing down the road an expansion in, all realms of education and healthcare provision. And it may change in a very positive way our utilization of the internet.
I want to turn to Dr. Bonds and ask him about the question of mental health and COVID-19 from a public health perspective. And as we talk to Dr. Bonds, I want you to consider that he is Chief Medical Officer of Los Angeles County, which has 10 million residents, which is larger than 40 states. It's just slightly smaller than the state of Georgia entirely. And so with that scale in mind, I was hoping, Dr. Bonds, you could give us a sense of how people are doing on the ground in a county like Los Angeles County during this pandemic.
Well, thanks for that intro, Brad. Now you remind me why I'm having so much trouble sleeping at night.
There you have it.
As I'm sure a lot of my co-panelists are. In LA County, we are huge. We're massive. We have about 250,000 unique clients that seek services with us each year. And since this has all started, that has slowed down a tiny bit in terms of crisis calls and emergency calls, which was a little surprising, but we think early on people were actually out seeking the creature comforts, the important things like figuring out where they could get toilet paper or whether they were going to be able to pay next month's rent. As time has progressed, we're definitely seeing an uptick in people seeking services that have previously maybe been sheltering, and now they're beginning to realize that I can't go off my medication. We certainly feel strongly that it's important to keep a connection to folks. And
if I may, I want to ask you about medications. During this crisis, are traditional psychiatric interventions, medical interventions, are they seen as effective, or do psychiatric professionals need to look for different solutions because we are in such incredibly unique times?
Well, certainly medications are often efficacious with specific diagnoses. If you have a chronic psychiatric condition like schizophrenia or bipolar disorder or major depression, medications are the mainstay of treatment alongside good supportive psychotherapy or insight-oriented therapy. But for many of the folks that come to treatment for the first time, what they may be experiencing is an adjustment disorder or reaction. Those can have anxiety or depression attached to them, but they're kind of self-limited. They're really a response to an acute trauma. Right. Most of my co-prescribers would not go for medication as a first line. Usually it's supportive psychotherapy psychotherapy, doing some crisis work. I think grief and loss is an important part of this pandemic as well. And we often find that being able to talk to someone, having a caring person across from you that you can have a conversation with is equally important. And then if things progress and don't get better, and certainly if people have serious symptoms like hallucinations or suicidal thoughts, then we would move more rapidly to medication. But generally, we try to wait some time before going to them first.
I want to ask all of the panelists about grief and loss. As we know, in the United States, over 80,000 people have died as a result of COVID-19. My family, if you can believe it, we have been touched by that 5 times during the very early days of the crisis. All the individuals were in their 80s. They had underlying conditions. But what was so heartbreaking for the families that have lost folks is that we couldn't be with them when these individuals died, and there have been no funerals. And so I'm wondering how you, as mental health professionals, are helping folks go through that grief process in a way that before COVID was just incomprehensible. Why don't we start with you, Dr. Bond, since you were talking about grief and loss?
Well, first of all, my heart goes out to you and your family for the loss. I personally have experienced the death of a close friend. It turns out that he was a photographer and was, up until the moment that this all hit, was trying to convince me I should go to Burning Man with him, where he was an official photographer. And that won't be happening, but there's a photograph that he took, which sits by my front entrance to my home. And every time I leave or exit, I'm reminded. And so it's kind of constantly there, as I think is true. What I've been trying to encourage people to do is to think about life as very precious and it can be fragile. And I think having that appreciation makes you aware of how much you need to do to protect yourself, that you can't change the past and you can't prevent what's happened, but you can take good coping strategies and affect them in your own life. I would say that we've tried to get people to meditate. One of the things that we've done as a county is we've bought licenses so that every Los Angeles resident can utilize one of the commercial apps out there. It's called Headspace. It's one of the common ones. And it's allowed people to find out how to be in the moment, to be in the present, in the here and now. I think taking it day by day, step by step, is really important in situations like this.
Dr. Scott, I want to get your sense on that question of grief and loss. Estimates have maybe 150,000 dying by August. So many of us will wind up knowing people that have died. And this is such a unique situation where you can't be with your loved ones when they die. You can't even hold a funeral after they pass. And so from a mental health perspective, how are you counseling your clients, patients, students during these incredibly unique times on this question of grief and loss?
Sure. I would say 5 or 6 things almost in a preventive way to anticipate that, you may.
We may be losing Dr. Scott. While Dr. Scott's Zoom gets back to buffered, can we ask you that question, Dr. Walker? How are you helping your students through this process? Any patients you may have?
I think we have Dr. Scott back here.
Dr. Scott, we had lost you, so if you could maybe pick up the question again. How to get
am I back?
Yeah, how to get through grief and loss in these unique times.
All right. So first would be, and for those that heard it, I'll repeat it, identify who might be at risk for loss or vulnerable in your own life, an elderly, someone with an underlying condition, and make sure you're doing everything you can do to make sure they're safe so you don't feel guilty if there's a negative outcome. For those individuals who are at a higher risk, I would recommend going ahead discussing in advance how you might keep in touch with them, plan this out beforehand should they have to go into a hospital. So that could be making sure they have a device, it's pretty simple, that they know how to use it, that it works, so that if there's a sudden hospitalization, you can maintain contact. That would be important. Third, you would need to practice using that device. And you can.
I'm loving everything he's saying. I hope we can get the Zoom link back because these are such great points. As he's rebuffering, I remember where he stopped. Dr. Walker, what's your sense on this question?
Yes, I've been thinking about this recently when I've heard of so many individuals not being able to observe commemoration in a
Right.
typical funeral procedure. And of course, funerals include the central ingredient of contact with others. So in the absence of that, the grieving process can be thwarted. The process is interrupted, and that's unhealthy psychologically. So one of the things I've thought about lately is that we should extend the lessons we've learned from telehealth and telecommuting to important human rituals, uh, like grieving, funerals. In the confines of human distancing, we can still observe many aspects of those grieving rituals. In mourning, we can gather online together and arrange to be in touch with each other in a way that allows us to at least provide some of that human contact, if not physical, remote, so that once we're able to again unite, we can perhaps appreciate more the rituals and traditions that have surrounded grieving and loss.
Such great advice. Over the weekend, I was on a Zoom call with relatives aging in range from 15 to 95. And it was so cathartic in so many ways. And so I get it. I mean, you can Zoom a commemoration, and that may not be perfect, but it is where we are today. As long as you're still on the screen, Dr. Walker, I want to ask you about parents and their children, teenagers, young adults. They're being forced to stay home right now. Some of them may be high school students that are used to running around, college students that are being forced to come home. With that in mind, what would you say to parents who are trying to work with their children? Maybe they're starting to exhibit some symptoms of depression or anxiety as a result of COVID. Or maybe they're starting to exhibit symptoms of some serious psychiatric issues, which often onset, as you know, around high school and college.
Yes. Well, certainly we don't have good data yet, good research studies on the mental health impact of COVID, but there has been research following epidemics like SARS on the mental health impact, and there's no doubt that it was associated with increases in anxiety, depression, stress. And speaking from experience working closely with undergraduates at Emory, finding themselves suddenly thrust into distance learning, having to leave familiar surroundings in their dormitory, leave their social support network, it's very stressful. But for individuals with pre-existing mental illness, the stress associated with abrupt, unexpected change is amplified.
Oh, yeah.
So many of the families that we work with have adolescents or young adults with serious mental illnesses. And suddenly, these children who were previously in educational settings or treatment settings are now home doing remote schoolwork or remote treatment. And these situations are very challenging for
It can
parents.
be volatile at times.
Yes.
Is that fair? It can be very volatile. So
Yeah.
would you recommend that parents seek out mental health professionals during this time, be it through telemedicine or otherwise?
I would recommend that they seek out treatment if they do not already have treatment providers. Fortunately, myself and most of my colleagues have quickly transitioned to telehealth work. And I would recommend to parents, especially if they have a child at home who has experienced a mental illness and is vulnerable, try to stick to the regular schedule as much as possible. Waking times, bed times. So have a regular but flexible schedule.
We're going to get to Dr. Bonds in a second. I want to go back to Dr. Scott, though, because I was so enjoying his points. He had 3 out of 6 that he
Yes.
listed in terms of how to, I guess, maybe anticipate grief and loss. Dr. Walker gave us some great advice, kind of have a Zoom commemoration, a Zoom memorial. Dr. Scott, please continue, because I was really enjoying your 3 points. Now we have 3 more to come.
Thank you. I think I can report the first case of COVID-infected internet. So
Exactly.
it collapsed on me. Yeah. So we talked about making sure if you had someone that was becoming ill or at high risk, having a device on that device, they could know how to use it, communicate with you. Should they have to communicate with you remotely in the hospital, they could, as 4 and 5, have activities on that device, pictures of loved ones, things that are reminders, healthy sort of updates. And this last part's a little bit difficult to talk about, but it's a realistic thing depending on if you have someone in your family who's very vulnerable. And that is, what kind of care and how extensive of the intervention care do you want? And so there were articles published, some recently, about certain individuals, more likely seniors, older people than not, who are now trying to update their living wills to say, I do not want to put on a ventilator whatsoever. And so some people may have different viewpoints of the risk of coming on or off a ventilator, what that means for them. And it's really going to be unique to the patient, their risk. It is a high risk if you come off a ventilator of not having as a positive outcome as if you don't go on one. So people are rethinking that. But that decision really should be at least discussed different updated of COVID-19 and making informed consent for updating your living will. There was a really nice one by University of California, San Francisco called Prepare for Your Care. Easy to Google and find, and it kind of walks you through and has an update for folks to think about COVID-19. So at least a loved one who is separated and trying to make these decisions for someone who may or may not be on a respirator, or at least have some input into that. So I think that would be another important point.
I want to go to another area that we're facing during this crisis, and have Dr. Bonds and Dr. Scott address this, maybe even Dr. Walker, and that deals with those that may start to be suffering some paranoia, which I could understand could be very likely. I mean, when there's a virus circulating around the world, I can see people starting to kind of exhibit these thoughts that someone's after me. And are you starting to see an uptick of that, Dr. Bonds? I mean, you are in Los Angeles County with 10 million people.
Right. Well, I can't say that I can speak to specific cases of paranoia here in LA, but we do know that from the literature, there is an association between this virus and psychosis that's new onset. My director, Dr. John Sharon, actually texted me, I think it was an 11 o'clock text last night, because we've been trying to figure out what are going to be the neurological and psychiatric sequelae of COVID. Like many viruses, it does affect the central nervous system. We also know that people can have trauma-related changes, but psychosis is very specific.
Is that true? I mean, if I can ask you, I mean, do we have a sense that COVID-19, the bug, the virus, actually can have some neurological consequences? Do we know that yet?
Absolutely. We know that there are people who have ongoing movement challenges. There might be cognitive challenges that come as a product of the virus itself. And that's not uncommon. I mean, certainly people can have a post-viral syndrome from a lot of different upper respiratory type illnesses, but this is one that we're still learning about it. And so there are anecdotal reports that are coming out. But paranoia, just for the audience who might not be mental health professionals, is very specific. It usually manifests itself by a lack of reality testing, meaning you experience something that isn't real. You think that people are after you, like you pointed out. I think one of the first clinical assessments you want to do is this real or imagined? There are a lot of fraud scams that are out there right now. There are certainly a lot of folks who might be concerned about their safety because they're maybe undocumented. They might wonder if participating in services is going to put them at risk. So sometimes the paranoia is well-founded, but if there's no solid basis for it, then it could be representative of a severe stress reaction. And it could also be a product of substance utilization. One of the unhealthy coping strategies that we have seen is that people resort to comforts. Alcohol doesn't usually cause psychosis, but certainly in late stage, if you're a drinker, you can begin to have hallucinations. If someone is using methamphetamine or stimulants, all of those things can put one at risk for paranoia. And certainly, even though for some folks, their habits have gone down because they don't have access. For others, their use of these substances has gone up. So I think that's always in the clinical equation. If they're, say, using more of their drug of choice or getting it from a different supplier than they're accustomed to, if it's a street drug, then you have to put that into the clinical assessment. But at the end of the day, paranoia is a serious symptom. And if you see it from a loved one, it is very important. It's one of those mental health red flags, like, thoughts of hurting yourself or others.
Right. Are we seeing anecdotally or otherwise an uptick in folks that may have had success with sobriety, but are now struggling to remain sober during this pandemic?
I would say yes. We don't have actual numbers yet. Typically, the epidemiology behind something like this lags by a few months. But we have certainly heard from our clinicians that a lot of folks, when they were holed up at home, they began to go back to some of their not so great habits. And in some cases, that was food, but addictive behavior, be it gambling, the internet, some people overindulging in things like pornography because there was no boundary.
Right.
And sometimes they were not supervised in the way that they might have been. Going into work is a very stabilizing thing if you have a job, and being at home with all this free time and sometimes idle time on your hands because you can't work effectively means that you might seek out things that are not so helpful as a part of your mental health.
I want to move on somewhat and talk to Dr. Scott about stability and those that have faced a stable life inside jail or prison. I mean, there is stability in that. And what we know is a lot of states, including California, are releasing folks from the prison system early because of COVID outbreaks and otherwise. What have you learned about the mental health impacts of these early releases for those that had been incarcerated but now find themselves all of a sudden out of the system?
Yeah, so a couple of things. First, nationally, in addition to certainly California, because of the issue of social distancing and the concern about crowding in a correctional environment, be it a jail or a prison, there has been a significant release of inmates, both in the county level and statewide level. And in some counties, up to a third, or some prisons up to 25% or a third of the jail and or prison release. So significant numbers. So I've talked to different psychiatric chiefs, if you will, of different facilities. And because of the rapid pressure to try to have less crowding in a jail or a prison, and therefore prevent COVID from going rampant inside a correctional facility, sometimes they have less than 24 hours before they even know the inmate might be released.
Wow.
If not even that much time. So I was asking one of the chief medical officers earlier today, how much time do you have to prepare for either reentry, access to services, connecting them to housing? And he said, sometimes we don't even know they're gone. The district attorney or the court has authorized that they be released immediately. And there are even lawsuits now in California, for example, suing the correctional system if they don't release prisoners fast enough to make social distancing more viable in the correctional setting. So you've got those competing demands. So back to your main question, what does this mean for people who may or may not have been prepared to release? I would agree with Dr. Bond said it's too early to tell. We don't yet have the data. This has been happening the last couple of months. But some early reports show that those that don't have housing, there is an increase in homelessness in certain jurisdictions if they don't have housing. And certainly if there's not preparation for alcohol and substance use, if it's fairly sudden, that can increase the risk. Some of the inmates were due to get out shortly anyway, so that reentry planning had started. So I don't think it's going to be universal. I think it's going to depend on how far you were in and what your unique issues were. And I just wanted to add one point. I think Dr. Bonds did such a nice job on the substance use. What I would say with individuals with paranoia pre-existing due to schizophrenia or psychosis, I would add the use of marijuana as a significant contributor. A lot of the studies show it rekindles paranoia, psychosis. Many people think, but this is an ill-informed thinking, that marijuana might just chill out or calm down people with mental illness, but it is bad for people with psychosis. And so certain cities, for example, to help deal with the homeless and the mentally ill, San Francisco, for example, is making sure they have access to marijuana or medical marijuana. But I think one would have to use caution if that was for all people a wise decision.
I want to ask Dr. Walker about that. As you know, in California and many states, marijuana is legal, not just for medical purposes. And it was funny, we kind of joked that these marijuana stores that we have in California, they were deemed essential businesses. And so I ask you, as an expert in teens and young adults, Dr. Walker, where do we go with this question of marijuana use for our young? Because look, I'm the father of an 18-year-old and 16-year-old, and I think they're good girls, but I have no doubt that there's a lot of increased marijuana use among the younger populations, especially in states where it's so easily accessible. Kind of expand on that as it relates to questions of mental health in the era of COVID-19.
Well, I teach an advanced course in schizophrenia and other psychotic disorders. And one of the things that I emphasize is the research that's been conducted by other investigators and us on the relationship between cannabis use and psychosis. And there's no doubt there's an association. So one of the things I encourage my students to do is think carefully about it, because as Dr. Scott pointed out, the assumption is that it's a de-stressor, and the initial reaction for many people may be an increased sense of calmness or well-being. But in fact, if you look at the biological data, cannabis in most people increases stress hormone release. So the irony is that the same agent that you might think is contributing to relaxation, ultimately over a period of time, 30 minutes, an hour, increases the activity of stress systems in the brain. And we think that that is one of the reasons why it can contribute to suspiciousness and paranoia. So the very worst thing to do if you're feeling stressed, socially isolated, or suspicious or uncertain is to smoke cannabis.
Interesting, because I've heard anecdotally from various folks that it can be helpful, but those are anecdotes. I don't live on anecdotes. I live on studies. And that's why I'm so glad, Dr. Walker, that you're providing us with this information. We've gotten some questions from the audience. So by the way, if you have any questions, you can send them through Facebook Live or through Zoom. And our first question, I guess we'll send it to Dr. Bonds because he had addressed this issue, is with regard to the neurological elements and how the virus impacts your neurological health. Does your neurology get repaired? I guess you could say, forgive me, I'm trying to figure out the medical terms. I'm not a doctor, but will your neurological symptoms resolve once you are recovered from COVID-19? Do we know?
I don't think we fully know the neurological impact. I would say at this point, it's probably a spectrum, as are most things in medicine. In medical school, I'm sure Dr. Scott could attest to this. You talk about a third, and a third, meaning that a third will go on to fully recover. A third will have some maybe dwindling symptoms, but there's a third that will be permanently impaired. So we probably would find that it would fall into that same spectrum. But the specific impairments that I've read about have to include like new learning, memory, attention and concentration. And I know that having spent many years doing hospital-based psychiatry, or what we call consultation and liaison, that people, when they have a serious medical illness that requires them to be mechanically ventilated on a respirator, they can develop a number of syndromes that include delirium, where there's losses of memory and consciousness. And sometimes people recover, but sometimes there's always a little bit of nagging sensation that I haven't quite fully recovered. And I think that's one of the reasons why we're going to set up our neuropsychologists to make available that type of testing. I think this is a part of the COVID recovery. I think at this point, we're just monitoring the literature to see what's being reported in these case reports. And about a year from now, we'll probably have a better sense of where we are with it.
We have another question, and that is, with a record number of people losing their job, over 20 million we know, many will lose their health insurance. How will that impact mental health care? Why don't we?
I'll chime in a few points, but then I expect Dr. Walker could add as well. So certainly the loss of employment is going to be a significant risk factor for adversely impacting mental health care, and then access to mental health care as well. The government has done a couple of things to help make tele-access to mental health care more available. So removing the restrictions from Medicaid and Medicare for in-person site visits and allowing more telepsychiatry is one. Removing some of the restrictions about prescribing certain drugs without an in-person evaluation. So there is some already governmental action to increase, but looking at there are 4 or 5 things that likely increase a person having kind of a adverse reaction on top of COVID-19 and how that may impact them from a mental health standpoint. Certainly unemployment is one, pre-existing significant mental illness is another, recent bereavement or loss of a loved one would be a third, having a catastrophic illness on your own or already being ill would be one, and any aggression or harm to self or others would be an acute risk factor in that context. So those are sort of 4 or 5 big warning signs.
We have another question coming in through Zoom. I think I'm going to send this to Dr. Walker, but anyone can respond as well. Our guest is asking, could the panelists share some symptoms that are evident in children and young adults that parents can look for and strategies to address them in the home without medication?
Yes, for sure. Although I should note that in the case of a child who has been already prescribed a medication for depression or whatever, it's very important to continue that in a stable way. But in general, often you'll see things in children who are stressed, like avoidance of social interaction, retreating to their room and staying there for extended periods of time. When that happens, I think it's important to try to engage the child in social interaction with other family members, keeping in mind, especially for teenagers, that peer interactions and socialization are a key part of their developmental trajectory. They need that interaction, and they're being deprived of it now. So to the extent that family members can intervene more often socially, that's important. Making sure they're not isolating themselves. If they express the need for mental health care, are concerned about stress, then I should also note that there are now many mental health professionals who are available and provide HIPAA-protected online therapy and counseling.
Dr. Bonds, I want to ask you, by expanding that question, what if it's a spouse or a partner that you are starting to see exhibit symptoms that are causing you to think that there may be a bit of a mental health event on the horizon during this pandemic? What would you recommend a spouse or a partner do?
Well, I think you're asking for the grown-up version, so to speak, but to
Yes.
echo some of what Dr. Walker was saying, any change in habits, and we're thinking about habits that are pretty basic, how much food someone's consuming, whether it be too much or too little, someone who's not eating, how much they're sleeping. You know, depression is often accompanied by a desire to just stay in bed all day, even though there's no reason for them to be tired. The alternative is people that have insomnia, which is really, really common. I think it's a very big part of an acute traumatic stress response. And I think especially in the early stages of the pandemic, we were seeing that so many people were furiously monitoring the media. And great, it's good to have news. You want to be informed. But if you're obsessively information seeking and it's causing you to have a lot of anxiety, nervousness, irritability, someone who's normally very calm and mild-mannered starts to lash out, get very short-tempered, you might wonder, is there something going on? I would also say that the most serious red flags, if they start behaving aggressively or certainly violently, either towards themselves or towards others, people who express a sense of hopelessness or a desire to feel like they can't go on living or they want to give up, those are really serious symptoms.
I want to ask you about that obsessive desire and need to watch the news, because I have heard from many family friends that they may have one family member that has CNN on all day, and it's unnerving for the other family member. You know, it's a moment in time, but how do we deal with those dynamics?
I think it's very important to set limits with ourselves and also with others around us. I mean, I happen to have a TV in my office. It comes with the job, as it turns out, and cable is always there. And at first, I just had it on in the background, and then I realized, you know, they're repeating the same thing over and over again, and that can be re-traumatizing you. I think about my own reaction during Hurricane Katrina when I was, you know, I grew up on the Gulf Coast and was out on the West Coast then, but kept watching the news and was worried about my family and friends. And I remembered that setting a limit to say, I'm going to watch maybe the morning news for about half an hour, and then when I get home in the evening, maybe I'll tune in to see what's happened during the day. But setting that type of boundary so you have specific moments that you check in is important. I would say another very, very important aspect of media consumption is go to reliable sources. There are a lot of fraudulent websites out there that are sending out fake news. And I mean, that term has a lot of associations, but you want to use a reliable source like the major networks, the newspaper, where something's been peer reviewed and it's been validated, and it's not just someone's website where you might get information that's misleading.
Dr. Scott, how would you advise someone who is having difficulty convincing a family member to limit their news consumption in the way that Dr. Bonds recommends?
Yeah, I think it's going to depend on that particular family member and what conditions they may or may not have. For example, if you have a very paranoid, psychotic, you know, person that's having regression into a mental illness, one has to be careful about being too confrontive in that situation, and maybe more getting an emergency mental health contact if it's primarily due to relapsing or deterioration from mental illness. That stepping aside, I absolutely agree with everything Dr. Bond said, that it's important to have sort of a contract, if you will, about how we're going to live and the best we can in the best kind of harmony in this house. And so rules of engagement and disengagement from the news. I think that 24-hour news cycle can be very detrimental. And it is, I agree, almost re-traumatizing. So I would say kind of have a contract of how we're going to survive it. And that person may have to give up that and have a negotiation with it. I mean, the other things that we've already touched on that are important, sort of limiting, although it's easy to start to drink a little bit more alcohol, or definitely cook the extra pie you never cooked before in your life, and all that may be good to an extent.
Well, let me ask you, if I can ask you about alcohol, because Dr. Walker so wisely counseled us on the risks of cannabis. Are there risks of increased use of alcohol during these times?
Yes, I mean, the literature already has shown there's been a dramatic increase of people's daily alcohol use compared to before this. And so alcohol itself, although it's a temporary kind of anti-anxiety relaxant, it impairs sleep, it disrupts sleep. It's actually a depressant, though people don't think of it in that way, because they have they kind of feel good. For many people with an underlying mood disorder, such as bipolar disorder or depression, it can worsen that. Yeah, so a lot of adverse. So I think really saying, okay, we've had our party month. This might be for the long haul.
Right.
We've got to simmer down now, and we've got to calm down and get to a rational pre-use and really watch it.
Right. As we are accepting more questions both on Facebook Live and Zoom, I want to turn to Dr. Bonds, who spoke with some fellow Emory alums and asked them, how are they gardening their personal mental health? And I know that you have some imagery to show us of some of your classmates. So why don't you tell us, Dr. Bonds, what you learned about how your fellow Emory alums are dealing with this crisis?
I do indeed, Brad. Thank you so much for asking. I have a tiny social media following. Hopefully you can see the image that's coming up.
Yes.
Okay, so I put out a challenge. I called it the Emory Wellness Challenge. And I asked fellow alums to post a photo of themselves wearing their Emory gear, be it a hat or a t-shirt, and doing something that helped them to relax during this crisis. And I got some interesting responses. I called it sort of informal social media research. This is Darcy Levit, who, and Charlotte, her dog, who works in the Emory Alumni Office. She's the Regional Director of Engagement with Washington, D.C. And Darcy and I have worked on the Emory Alumni Board together, and I was really pleased to see that she wasn't the only pet lover. A lot of people have been taking this opportunity to bond with their furry friends. This is Amy Toy Rudolph and Sophie, and then Lauren Kutroberry and Chumley. Obviously, a lot of my social media friends are from the 80s era, so I'll leave it at that. But they look a lot better than I do. I mean, these women are amazing, and their dogs seem to be keeping them warm and happy. The other folks were outdoor people. This is Ginger Hicks Smith, who I met at a Herman Award ceremony. She is out and about in looks like a rural area. And then this is Greg Pharo, who was a former wheel editor when I was at Emory. And of course, this is yours truly, looking very pre-barber with the background is the Oxford Basin, which is an area that's an animal preserve and wildlife preserve in my neighborhood. There was another one of someone sleeping, but I didn't really get consent or permission to post that. But I thought that was a collection of outdoor activities. Often, you know, I was pleased that we're wearing facial masks, as we should be doing right now if we're around other people. But it was quite fun. And the Emory Wellness Challenge, you can do it on Facebook or you can do it on Instagram if you'd like to join in the fun.
I want to talk about that outdoor experience. We've heard in the news that the kind of stay-at-home crowd versus the reopen crowd, they're getting more entrenched in their positions. And sadly, there have been acts of violence against some folks because they've asked members of the public to put on a mask or whatever it may be. What advice would our panelists have for those of us that may be out and about, and someone is engaging in behavior that doesn't feel safe during this era, and you feel like you're at risk, but you're not really sure how to minimize that risk based upon that other person's behavior, whom you may probably not know? Why don't we start with Dr. Walker?
Well, that's certainly a challenging question. And it's something I would be cautious about. I'm trying to abide by all the guidelines when I go out for essential errands. I wear a mask, sometimes gloves, depending on what I'm doing. But certainly, I've noticed a high level of conscientiousness in the community I live in. I know that's not consistent, but were I in a social situation where people seem to be kind of violating the space that's healthy, I think I would feel comfortable saying something about that. It is a public health issue. People don't object to signs in restaurants that say must wear shirts and shoes.
Right.
I don't think we should be offended by a public health measure to protect other people.
We have a question from the audience, which applies to me as well. How can parents handle teenagers who feel they are missing out on milestones in life, like high school graduation, my daughter, their second semester of senior year, their prom, etc.? What do you think, Dr. Scott?
Yeah, so I just faced this challenge today we have a graduating class. They aren't teenagers, but they aren't that much older, and they're finishing their residency training program. Right. So we had to make the decision today. We would not have, and usually I do a very in-person, private dinner for them. It's a lovely family sharing event. And so we had to say, we're just not going to be able to do it. So for us, we're going to find many creative ways to make this special in advance. So we're going to have kind of assigned skits and duties and an awards time for it, a special time speaker. We're going to do the itinerary in advance. So
if I may, Dr. Scott, I am so impressed with so many institutions, Emory included, who is working to make their graduates feel special. I mean, it's amazing how creative they've been. But what do the parents say to the children who, like, it's the why me? Why did this happen to me? And I'm never getting this time back. I think I'm channeling myself. So you understand, like, as a mental health professional, what can we tell our children, our young adults, 18, 22, 25, whatever it is, that they're not going to get this time back? Yeah.
one of the things that we've been sharing with our students at Emory, the graduating seniors in particular, is the message that yes, this is unusual. Yes, it's disruptive. But you are going to be setting a precedent here and establishing new traditions. The faculty has done that. The students have done that. We have wonderful online speeches and performances. We even have some performances by very talented faculty who sang to the students. Some not so talented faculty who also sang, unfortunately. But I think taking advantage of the technology we have, fortunately, to confront this very unfortunate situation.
Another question I want to pose this to Dr. Bonds, if I may, given your work in public health. Now that so many individuals have lost their jobs, which means also their health insurance, what mental health services exist that are free for those without insurance? Where can they access these services? I mean, I assume each jurisdiction is different, but I'm sure you can answer the question generally.
I sure will. And that is a critical question, especially as we talk about grief, loss, trauma, and also the impact of this virus on mental health for folk. Most cities and counties have some form of public health assistance. In fact, the group of folks that we work with here at DMH are primarily those who are underinsured or uninsured. Call your local health authority. In our case, it's divided up between mental health and physical health, but you can look for Los Angeles County Department of Mental Health. You can probably do that in any jurisdiction. I know that Atlanta has a very robust public mental health system, and you don't have to have funding. Fortunately, our federal government supports some degree of service through the Affordable Care Act, and people who didn't previously qualify may qualify. And a change in life event generally allows you to go into the system. If you lose your job and lose your insurance, that is a qualifying event to where you can change and maybe acquire coverage through the safety net programs that are out there. I would say it's also important to know that there are crisis lines that are available in terms of national suicide prevention hotlines. It's different in every area, but there are ways that if all else stops, call 911 or call 411 to ask questions about how you can get connected to those local health authorities.
Have we seen a spike in suicidal ideation during the COVID-19 crisis?
This is one of those questions that we'll probably know more about later. Suicide, believe it or not, is a relatively rare event. Even though we can look at national statistics, it's hard to track it on a week-by-week basis because it's not something like heart attacks where they're happening a lot. I would say that just in my area, we've seen a few more high-profile deaths that are likely linked to COVID, but we also don't really know. I mean, I think those types of public health analyses will happen after the fact, but I think we have seen more people that are distressed and in some cases making attempts. And, I don't want to go into the gory details, but I would just say that those things stand out to me. And I think that we probably expect over time that with anything like this, it's the recovery that's going to be very difficult. People realize they've made it through, they've lived, but their life has really changed. I did want to go back to your earlier question because I was thinking about how do you talk to young people? Well, I think about how do you talk to adults, because a lot of my patients that I encounter, I have a small private practice, it's about this change and this new normal. And I try to help them find a silver lining. In LA, we're besieged by traffic. And right now, if you have to go anywhere on your essential errand, there's very little traffic. It's beginning to tick up a bit. I also think about the clean air. I look outside my window, I'm on the 12th floor, and I can see the hills, and I can, if I were on the other side of the building, maybe see the ocean, which wouldn't have happened at this time of year before. I think another thing is that this is a new normal, and to think about what changes have I made, what connections have I reinforced. There are friends and colleagues that I haven't heard from in years, and maybe it's the 5th week of the crisis, but at least they called me or they sent a message. And I think making those connections, like my friends on social media that sent me messages and images, those are really precious things that wouldn't have happened. And lastly, I'll say that if you think about what happened post 9/11, we had TSA. At first, that change was really uncomfortable because change is hard. Now we don't think twice about going through the security screenings because we realize it's for a purpose. The same is true when other natural disasters happen. There are things that we put in place that are stopgaps. And some of the things after COVID will be there with us for a very long time. But I think it's about adjusting and just letting yourself have that time to change.
We have time for one final question before final thoughts. And the question from Dr. Ditter is, we are starting to see patients who have had COVID Any comments on treatment, in particular about treating the PTSD from ICU delirium? Who wants to take
Yeah,
that? Dr.
yeah,
Scott?
I mean, I'll just talk about, I mean, certainly under the diagnostic manual, if a person felt that they were going to die and this was a life-threatening event, they could meet criteria for PTSD. So the first thing, and anytime you do a good evaluation of PTSD, is what are the criteria, what are the specific symptoms, and you make sure you implement, I would say at this point, the same evidence-based treatments for both medication-wise and psychotherapy for PTSD. And so one, be familiar with the symptoms, document what those symptoms are, don't dismiss it, and implement appropriate evidence-based therapies.
In our final moments, I'd like to turn to our panelists and ask them for some final thoughts. If they were to offer any tips to our audience about managing their own personal stress, about maintaining their own personal emotional health, what would you offer? What takeaways do you want to give out after this excellent 1 hour conversation? We'll start with Dr. Walker.
Well, I think Dr. Bonds gave some
He did.
excellent recommendations for framing things. This is a dramatic change, and there are some aspects of our accommodation to that change that we may continue to practice. Other precautions will eventually no longer be needed. But in the meantime, as we're going through this, I think a critical issue is to think about the fact that this is a shared experience. And if you're feeling stressed, you're feeling sad, if you're feeling lonely, isolated, that you are not alone. This is especially important for young people for whom breaking those social networks can be so disruptive. Your peers are feeling the same way. Reach out to them. They'll appreciate it.
Lovely. Dr. Bonds.
I would say establish some new healthy habits. And although that might sound cliche, I think because so many of the structures and boundaries in our lives have been taken away, then you need to create something that's new and healthy. I talked about meditation earlier. I know that I increased from 2 minutes a day, and it seemed like I never had time to do 10 minutes, but now I've gotten there, and I noticed that there are physiological benefits. You stay calmer, and it's really for other people, I think, because they like me better when I have done the meditation. And in terms of like exercise and working out, there are no gyms, but there are plenty of things that you can do at home, calisthenic routines you can download. There are apps that you can use. Just establish some new routines to replace what you may have lost, and to embrace those things and think about what challenges you face, and just to think about everything as day by day.
Right. Dr. Scott.
Yeah, I mean, I was going to say many of the same points, and to add on to that, I agree, kind of keeping some routine. And when I think about, other epic survivors and situations and terrible times, there's one psychologist that talked about one of the worst episodes in people who survived concentration camps, for example. And this was a man called Viktor Frankl. He had a kind of therapy called logotherapy. But if it's a very difficult, stressful, confined time, what was the answer for those people who made it through? And the answer for those who seemed to have a better outcome? And it was that they were able to assign meaning to the experience, even if the experience was a terrible experience. So think of and learn and assign a meaning, much for what Dr. Bonds and Dr. Walker have talked about. So either having a new goal, learning from it, reaching out, reconnecting, and that meaning will help get you through.
I want to thank our panelists so very much for offering such sage wisdom and advice. Dr. Elaine Walker, Dr. Curly Bonds, Dr. Charles Scott. I also want to thank the remarkable team at Emory University who put this panel together. They are Venus Austin, Elizabeth Chapman, Jamina Cole, Lane Conville-County, and Chloe Cochran. I know that these are times like none other, but I am so heartened to know that we have an Emory community in which we can turn. I'm a new member of the community, although my wife is a graduate. My daughter will be at the institution. And so I just want to stay healthy, stay safe, and thank you so much on behalf of Emory University. Thank you so much.
Thank you for having us.
Thank you.
Bye-bye.